Hello, Andrew Colsky here with Stop My OCD, and I am very excited to have Madina Alam. She is a therapist and she works with NOCD, and she's going to share with us all about how the company works and her own experiences with OCD. So, Madina, welcome. Could you introduce yourself to the audience?
Yeah, of course. Thanks for having me. I'm also excited. Like Andrew said, my name is Madina. I'm both a therapist and one of the directors at NOCD. And yeah, I get the pleasure of working with the actual clinicians in the network, but also working with members themselves.
Mhm. Great, fantastic. Well, I have a lot of questions for you because I get a lot of questions about NOCD from people that I speak to. So I'm hoping we can answer a lot of those today. Um, so just to start us off, can you tell the audience how did you personally get interested in working with OCD?
Yeah, I've answered this question a couple times, and I honestly, it never gets old because I kind of love my story on finding ERP. So after I had done my after I did my undergrad work, I actually took a year off and went to yoga school and just taught yoga for a year straight. And I got really into a lot of like the Buddhist philosophy. I'm not religious or anything, but a lot of the philosophy in Buddhism is very similar to ERP. And so I was actually reading a book called Comfortable with Uncertainty, and I had gotten recruited actually by NOCD. And when I was listening to the type of therapy that they do, ERP, I was like, wow, this sounds so much like what I'm learning in yoga school, because a lot of it, again, is about teaching people that uncertainty and discomfort is part of life. And so at that point, I had really known that I think this would be a good fit for me, just because I truly believed it deep down in my own soul and like believed in those skills because I had seen them work for myself. And I don't even have OCD, but I know that it's a very applicable skill that's very useful for a lot of populations. So then once I started actually learning ERP and implementing it, it became even more clear how much of an impact it can have on people, and especially with people who have OCD. So I kind of say that ERP fell into my lap, but for very good reasons.
Hmm. Wow. So just for our audience, when you talk about ERP, you're talking about exposure and response prevention therapy, which is a main sort of gold standard therapy used for OCD treatment. Um, I agree with you. Personally, it was interesting for me when I started, and to see the results was
Yeah.
really amazing because people can be so distressed when they first come in, and then you work with them and they can really make a big change. So I get it. I agree with you completely. Wow. Well, that's a great story.
Thanks.
So, so obviously then you got sort of the OCD bug, the interest in working with that community. How did that get you over to no CD?
Well, I didn't treat OCD until I came to NOCD. So that is how I found OCD treatment. And once I went through the training here and started seeing the members here, that's when I knew that I had a good love for it. Because yeah, you're right. You actually see people get better. And I think for us as therapists, that's I don't think something we all get to experience. I've been in settings where I don't experience individuals getting better, and that can be a lot, right? Because you're pouring into these individuals, and not seeing them get better can be difficult.
Yeah, yeah, no, I agree. So, so can you share with us, how did no CD get started? Sort of, what's the background story of where it all began?
Yeah, so NOCD was founded by our CEO, Stephen Smith. He actually has OCD himself, and he unfortunately went through several rounds of treatment that were not only not effective, but actually worsened his symptoms, which is unfortunately very common for a lot of people with OCD. OCD is misunderstood in general. It's one of the only mental health terms that are thrown around in like a casual way. And it's also very misunderstood within the mental health community. A lot of providers are actually providing interventions that are worsening symptoms for people who have OCD. And so unfortunately, Stephen went through that experience to the point where he was actually housebound. And then he did discover ERP and got better and saw that, and started NOCD, so other people wouldn't hopefully have to go through that same journey.
Wow. Wow. I didn't know that about Stephen. That's, you know, the need is really a great driver for innovation. So I'm glad to hear
Mhm.
that.
Yeah.
So tell us, so no CD exists, but tell us, what exactly does no CD do? Who do you work with? What do you do? What's the magic sauce?
Yeah, the majority of our members are people who have OCD. So I would say maybe like 90 to 95% have OCD. But we do also treat BFRB, so like hair pulling and skin picking, as well as hoarding tics. And we also have some of our clinicians trained in prolonged exposure to treat PTSD. And we treat all age ranges, which is really cool. So the youngest member we've had is 5, which is amazing.
Wow. Wow.
Yeah.
So for the hair pulling and the skin picking and those things, I'm assuming you all are trained and do habit reversal training. Is that right?
Yep. So the clinicians start with a very extensive ERP training, and that is the population they start with because that is the largest demographic here at NOCD. And then in the later weeks, once they've kind of gotten ERP under their belt, they do a habit reversal training to help treat skin picking and hair pulling, as well as a separate child and adolescent training. It's very similar adult versus adolescents, but there are definitely some nuances. So they get a separate training on how to treat younger individuals.
Wow. Wow. That's great. So it sounds like there's a lot of background training involved. Um,
Yeah.
so could you, that's actually was going to be one of my questions, because I get that question a lot from people, is, so what, how much training and support do your therapists actually have? Like, you know, are we talking hours? Are we talking weeks? Are we talking what type of support? Can you give us a sense of that whole thing?
Yeah, I think support at NOCD is ongoing. They get months of training and build up of that. So, the intensity of it is very high when they initially start, right? They're in training literally all day for the first week, and then they're still training before they start building their caseload. And while they're building their caseload, they're still training and getting that hands-on, that one-to-one time with, one of our advisors or one of our managers or supervisors, helping them with the cases. We also have a lot of consults throughout the week where they can review with supervisors, but also with other colleagues at NOCD. And I think that this is actually a really important question, because anyone who's looking for OCD treatment, if I had one piece of advice, it would be to make sure that you are finding someone who has training in this evidence-based approach, because at the end of the day, again, a lot of treatment actually worsens OCD symptoms. And that really actually saddens me, because a lot of people don't know that, right? We're told to go to therapy, and people, think for right reasons that they're doing the right thing by going to therapy. But, definitely interview your therapist before going on with them. Ensure that they know what ERP is, how it works, and that they're going to be able to effectively execute that treatment, because it's really effective. OCD is very treatable. And that's another thing a lot of people don't know.
Yeah, no, it's you hit upon a really important thing there, because if anyone has seen some of my other videos, there's two things that I talk about a lot, and that
Mhm.
is exactly what you just said. That if you're seeking someone to help treat your OCD, make sure you ask the questions. How much training do they have? What do they know about it? What type of therapy do they use? Really ask the questions, because you're hiring this person as a professional, and you have every right to know what their background is. The other thing that people, again, who watch my videos hear me say a lot probably, is when therapists go to school, whether it be a therapist, whether it be a psychologist, whether it be a psychiatrist, I have yet to come across somebody who has told me they learned about OCD in school. And so this
Yep.
is something that they all learn after school. And if they
Mhm.
don't take the course and they just try and treat it, they don't have any way to know how to do it.
Yeah, I have a lot of thoughts and feelings on this. Like to your point, when we graduate, we're not given a specialty. And if we choose, we can essentially be a quote unquote generalist, right? And so I definitely stay away from any therapist that claims they can treat like 20 different disorders. Like there's no way you're a specialist in 20 different disorders. Like for myself, if I experience someone who has something outside of my wheelhouse, and all our therapists at NOCD follow this kind of rule, if you will, we refer them out because we know that, I mean, I'm not specialized to treat personality disorders, for example, and it would be a disservice to an individual to take that person on and treat them. So yes, I think it's very important to interview your therapist before actually stepping on board with them.
Yeah, yeah. So the therapists that are associated with no CD, are these people that work for you full time, or do they have their own practices? Or I'm not even sure how that works, to be honest with you.
Yeah, we have full-time clinicians, but we also have independent contractors. So independent contractors a lot of times do have outside like other forms of employment, and they dedicate about 15 hours to no CD clients that we book them for. So that's like the independent contractor route, and then the full-time clinicians are typically, working here. And that is like the cool part of working here is you don't have to do any of the overhead piece of it, like advertising. We always have members that need to be seen and served. And yeah, so we basically fill the caseload for the clinicians.
Wow. So for patients, do they see the clinician through telehealth? Do they see them in person? Is it a choice? How does that part work?
It's all telehealth. NoCD actually was telehealth before even COVID existed. Fun fact, I actually got my job with NoCD like maybe 2 days before the official shutdown, which was very good timing for me. But yeah, the reason we're telehealth is for a couple of reasons. You can serve so many people via telehealth. So for example, I live in North Carolina, but I still have my New York license. So a lot of my caseload, I'm actually treating them all the way back in New York. And we know that finding an ERP specialist can be very hard, especially if you have to go in person. So that's a one reason we're just able to serve more people. And then also ERP is actually much more effective, in my opinion, virtually, because I have the individual in their physical environment, and I can also take them to a lot of different environments where exposures are really necessary. In the office, I'm very limited to what I can do with them.
Right. Wow. I'm I'm sitting here thinking to myself, you and I have, the same thoughts and same information on these things. We could probably finish each other's sentences because I'm right on, in line with what you're saying. It does because I get that question because I do primarily telehealth, and I get that
Mhm.
question. It's like, well, can't I come see you in the office? And the answer is, I actually prefer that you're in the environment where this stuff is happening because, you know, I've had people take their computer into the bathroom where they wash their hands, and we wash our hands together, and all
Right.
these things. So it's
Yeah,
really helpful to do the telehealth part.
I agree. Yeah.
So so how would someone pay for treatment if they came to no CD?
So we do accept most major insurance plans. Of course, as we all know, insurance is not as straightforward as that. So it does depend on like your plan. So that's definitely something you can work with our care team and your insurance on. And then, hopefully either, come for a small copay or maybe nothing at all. A lot of members do actually pay out of pocket. Unfortunately, the progression of insurance coverage for mental health is not where I personally think it should be. So a lot of insurance companies don't offer those benefits. Again, depending on your plan, they do offer a lot for a lot of our members. But I think, a lot of people, once they do start here, they realize how effective it is and that it's not something you need to necessarily be so engaged in for the rest of your life because it's so effective that you can start to titrate off treatment, that investment upfront is worth it, right? Because people who have OCD know that it's literally stealing their life from them. And so the money does feel very worth it at that point.
Yeah, no, absolutely. So
Yeah.
so if a person becomes a patient of yours, do they need
Mhm.
to have any special computer programs or special equipment to work with you?
No, a computer with some good Wi-Fi service is pretty much all we need. That's not 100% necessary. A lot of clients or members do go sign on through their phone. I can't speak for all therapists. I personally like if my member can sign on like in a dedicated space on a laptop, but a phone will definitely do as well.
Okay, but they don't need to download any special software or anything like
No.
that.
We
Great.
just use Zoom, which is pretty simple to download. Anyone can download it. It's free.
Yeah.
Yep.
Wonderful. Wonderful. So what about, are there certain types of cases that you do not take?
Yeah, so if someone presents with active lethality concerns, so suicidal or homicidal ideations, actively cutting, self-injurious behaviors, actively using substances, those are cases where we would rule out. Main reason being, if you're not physically safe, I can't possibly work on your OCD with you, so that needs to be stabilized. And then as far as substances, many of us may already know that that's actually a distinguishing factor on all of the disorders in the DSM is the individual has to abstain from substances because that does influence mental health. And we also know that substance use is actually a safety behavior because it's a numbing behavior that a lot of people with OCD find themselves doing because the thoughts are so uncomfortable. So that definitely needs to be handled prior. And then anything outside of OCD, hair pulling, skin picking, hoarding, tics. And if your clinician is trained in prolonged exposure, anything outside those disorders are referred out. Yeah.
Great, great. So, because people from all over the world watch these videos, where do you all operate? Who can become one of your patients?
So we accept members in all 50 states as well as UK and Australia. So that's very exciting. We're working on expanding to even more places. Some of our independent contractors, depending on their liability insurance, are able to see outside of those places. Like I know you and I were speaking on just the lack of service in other countries. So some liability insurances do allow clinicians to see people in different countries as well.
Mhm. Okay. We were talking about insurance and payment, and I know that's a really complicated area these days. One of the questions that I also get a lot, and again, I don't know the answer to this, is do you work with Medicaid at all?
Yes. So again, a lot of it depends on the plan. So most insurances we are accepting. Again, it's just dependent on the plan, and the best bet, even if you think we're not going to accept your insurance, I would reach out to our care team. You can visit treatmyocd.com and it will give you a prompt to sign up for a phone call. And then they can actually run your benefits for you to confirm.
Oh, that's great. Wow. Okay. That's good to know.
Yes.
So, I do want to take a minute and just talk to you about some interesting cases because, there's so many things to learn about them. And I think you alluded to it at some point that a lot of people think of OCD as, being really neat and washing my hands a lot. And it's so much more than that. Talk to me about, a lot of times we'll hear people say, well, I have puro OCD. What does puro mean to you? Tell us about your experiences.
Yeah, I mean, my understanding of people's understanding of puro is that there's no compulsions. However, I would say that I have yet to see that. I think every person that I've treated and diagnosed with OCD has compulsions. I think when people say puro, they mean there's no physical compulsion. So maybe they're not checking or cleaning or washing. Puro, I really see as someone who's probably ruminating a lot, and doing other, mental compulsions, right? Checking internally, maybe how they feel around a particular person, or checking to feel if they are going to snap and go crazy and hurt someone or hurt themselves. So a lot of it can be internal. And I think that that's actually really important in general, because if we were to only address the physical compulsions in treatment, the person is probably only going to see half the progress. Because an exposure to a scary thing is worthless unless you're actively helping the individual resist physical and mental compulsions, right? So if I have someone not check the door again, but then they're sitting there for an hour ruminating on trying to figure out if they did or didn't check it, that kind of defeats the purpose of the exposure. So I went off on a little bit of a side note there, but yeah, Puro, I think, in my opinion, is not technically a thing.
Yeah, again, like I said, we could finish each other's sentences, I think. And I have some other videos where I talk about types of OCD and also types of compulsions. And, OCD, obsessive compulsive disorder, means there's an obsession and a compulsion. And, like you said, the compulsion doesn't have to be physical, it can be mental, such as worrying, ruminating. And I even, there's an interesting study out that I did a video about that talks about why we worry, why we ruminate, how it fits in as a compulsion. So yeah, so Puro, I always say, is a misnomer. There is compulsions, they just happen to be mental compulsions. So we're on the same page with that.
I think too, like, I'm sorry if I could take that a step further. I think OCD is really tricky, and I honestly think and believe that Puro is a way of trying to get someone with OCD to not engage in ERP. Because if I don't have compulsions, how do I even do ERP, right? And also, it doesn't really matter the type of OCD in the sense of it's all treated the same. And I think that's also another kind of excuse that OCD throws out for individuals to prevent them from doing ERP. So if you do find yourself thinking that you have Puro, you don't have any compulsions, I would really maybe take a step back and be honest with yourself, in the sense of, not that you're doing this on purpose, but OCD is just a very tricky disorder. And I truly believe that it always tries to stay on top. And if I don't have compulsions, then I can't do ERP. And so then I will never get better, right? So I just thought of that while you were speaking.
Yeah, no, it is a really interesting area, and it also, I'll share another anecdote with you because it's relevant, I think. We were talking before about how the fact that OCD is not really taught in school, whether it be psychiatrists, whether it be psychologists, whether it be mental health counselors. And one of the things that I find is it's very hard to find a psychiatrist who is trained in OCD to prescribe proper medications.
Yeah.
And to this day, I have never had a particular psychiatrist that I feel comfortable referring people to. And so, you try out different things along the way. I had one patient who had mental compulsions. So, Puro, but not really Puro. Anyways, he had mental compulsions. He went to the psychiatrist to discuss medication options because he had a pretty severe case. And he came back and he said, well, the psychiatrist told me I don't have OCD because I don't have any physical compulsions. Now, this is a person with classic OCD.
Yeah.
There's a case where you see someone who's highly trained, they're a doctor, but they just never were trained in OCD, and sometimes they get it wrong.
Yeah, totally. Like the dosing, I see a lot of times, right? The dosing of Zoloft. And by no means am I a psychiatrist, but Zoloft oftentimes is used for depression in smaller doses and can be effective for OCD if it's done in higher doses. But a lot of times I'll see someone with OCD on a lower dose. And yeah, I think it's just another testament that even providers in the field aren't fully versed on it. And it's not their fault necessarily, right? I think there's just in general a lot of misconceptions. Like I would say maybe 5% of my caseload is like contamination and organization. The rest of it is, what if I kill my mom? What if I'm sexually attracted to my dog? All these things that you would never be like, oh, that's OCD. And so, yeah, I think just even if this podcast helps one person understand that it's not so linear or square defined, I think that'll, hopefully bring me some peace. I don't know. That's partially why you started this podcast, but yeah, it's scary how it's misunderstood.
Yeah. No, you mentioned, another one there that I was going to ask about, because for some reason in the last, oh, I don't know, month or two, I've had a tremendous number of cases and even podcasts related to people with sexual orientation OCD. And I find that one to be one of the more difficult ones because of the subject matter and the questioning behind it. In other words, people will say, well, how do you know it's OCD? Maybe the person is truly questioning their sexual orientation, or, one of multiple variations on that. Have you ever had to deal with that? And do you have anything to share with us about that?
Yeah, that's a really good question. And I think first and foremost, I always let individuals know that I'm never here to help you figure out anything, right? You may be the sexual orientation that you don't think you are, right? Maybe you've always thought you were heterosexual, but maybe you are in fact attracted to women. And I am not here to tell you that you aren't, or you are, or whatnot. I'm never here to gain you any more certainty. I'm only here to take out the energy and the time you're using to try to gain certainty, right? Because at the end of the day, none of us know what's even going to happen a minute from now. I mean, not to sound morbid, but you and I could both die today at some point, right? And I don't know that. And I don't necessarily know. I think I'm a heterosexual female. I don't know that though. But the best way I can get closest to that answer is to fully engage in my life. Because a lot of times what happens is, specifically with sexual orientation OCD, they're trying relentlessly hard to figure it out, that they're actually getting further away from the answer because they're, say they're with their partner, they think they're heterosexual, and every time they go to be intimate, they're ruminating on if they like it or not. And I like to bring humor to my therapy, and I ask them, like, when you have fun, do you have to think about if you're having fun, or is it just something you experience? And they usually giggle with me. And again, the only way that they can truly experience that is by being fully invested and not doing the compulsions of trying to figure it out.
Mhm.
But it can be tricky, right? Because, that is something that some people do have to like grapple with, right? Oh, I am not the sexual orientation that I thought I was. Think of things also in terms of excessive and time consuming, right? Is there some thought that goes into sexuality for all of us? Absolutely. But is it excessive and time consuming? Because it's not that you don't ever think about that, especially if that is something maybe you truly are questioning. It's the amount of time and the disruption it has in your life.
Right, right. Yeah,
Yeah.
it's just interesting how lately I've gotten so many of those, cases. Um,
Mhm.
there's one other that I want to ask you about, but before I do that, I can't remember. Did I ask you the age range of people that you all treat?
We treat all ages. I mean, 5 and up, right?
Okay, so
So,
kids as well as adults all the way to seniors.
yep.
Great. Okay, good. I wanted to make sure that we got that out there so people would know.
Yeah. Yes,
Um,
all ages.
so the other one that I wanted to ask you about, you and I had a chance to talk about this before, but the just right OCD. What has been your experience with that?
Yes, I think personally, Just Right is perceived as organization, right? I'm a really organized person. I color coordinated my closet. It can look like that. Again, honestly, in my 3.5 years of just treating OCD, that's probably like 2% of people I've seen. Just Right manifests in a lot of different ways. I need to feel just right. So think of relationship OCD. Why did I not feel that spark when Johnny and I kissed? Or how come I don't feel butterflies before I see, my girlfriend? Or, checking that internal feeling. I need to feel a specific way. Or harm OCD, right? Do I feel like I'm going to snap and go crazy? Like, is there some kind of weird sensation? There's a lot of like overlap with like developing, schizophrenia and going crazy and harming someone and needing that internal feeling to be just right. Needing to have like the just right amount of anxiety, right? I had a member earlier who was worrying about the fact that she wasn't worrying. And I was like, let's pause and laugh at that for a moment. I think you came here because you don't want to be worrying as much, but now you're worrying that you're not worrying, right? So she was essentially telling me she didn't feel right. It didn't feel right, not worry. You know, so many other things that I don't feel like I locked the door. I have like this, you know, nervousness feeling that must mean something. So there's just a lot of internal cues. And I think for me, no matter why someone comes to treatment, I'm always addressing their physical sensations, because just like thoughts can be intrusive, so can sensations. And what you need to teach someone with anxiety is that you don't have to be scared of a physical sensation. And it also doesn't have to mean anything, right? You'll see it also with POCD all the time, right? Why did I get a groinal sensation around a child? It's like, well, you know, as humans, we get groinal sensations for all particular reasons, and they don't have to mean anything. So, yeah, I think just right. A lot of times, even someone who is skilled in ERP, that's I think still a more like nuanced thing. I don't think I admittedly knew that up front. I remember, do you mind if I go into a little bit of a case story?
No, please.
About, yeah.
Interesting.
I'll never forget this case, because I was admittedly a little bit new into my ERP career, and I had no idea any of this was going on at the time. But I had this individual, and they had just right OCD, and it was very like traditional, like organization. I need to fold my clothes just right, this, that, and the fourth. So we made the hierarchy and everything, which those of you who don't know, that's basically the treatment plan of exposures from least to most scary. And I remember the first time I went to go to an ERP with her, I was like, all right, so what if we do this? She's like, well, I don't think that's going to make me anxious. Okay. So then I'm like, what if you do this? She's like, I don't think that's going to make me anxious either. And then I kept suggesting ERPs, and none of them, she said, would make her anxious. So again, me being a new clinician, I'm like, what the heck am I doing wrong here? And then, obviously I realized down the line, and I really see it now that I have more experiences, OCD was so tricky that it convinced the member that none of those were the right exposures, and that OCD won because OCD didn't want you to do any exposures. So we ended the session, we didn't do any exposures because none of them were the right ones. They weren't going to make me anxious enough. And so it's just another depiction that, OCD and just right in particular can interfere with treatment, because treatment needs to be done just right. And you'll see this too. Individuals want to do ERP just right, which actually gets in the way of them doing ERP just right, because they're ruminating on doing it right, that they're not doing it right. And so it becomes a self-fulfilling prophecy. It seems like you've experienced that before, but it's kind of wild. And I think too, like, if any clinicians are watching this, like if someone is saying like, I don't think that's going to make me anxious, I would encourage you to just say, just do it. Let's just see, maybe it won't. Because either anxiety knows it's going to be anxiety provoking and it's trying to get you to avoid, or I think that, but also I'm blanking on what I was going to say about that. I don't necessarily see it as a bad thing also if you're not anxious during an exposure. I don't know if you have the same sentiment, but typically if someone's not anxious during an exposure, they're not doing a compulsion, which I think is great. Typically when people are anxious during an exposure, they're usually ruminating, they're checking, they're, analyzing their body sensations. They're trying to figure out what that scene meant and how it applies to them. So for clinicians and for individuals doing ERP, try your best not to expect a certain response when you do an exposure. Because I'm not concerned if you're anxious or not anxious necessarily. I'm concerned that you're doing hard things and that you're not disrupting your life or avoiding things in your life because you're scared of something. So whether you're anxious or not, I honestly don't care, in the sense of I don't think that it matters all that much. Right. So yeah, I think I again went off a little. There's just so many directions I can go on, and I'm sure you can probably tell by now I get very hyped up talking about this stuff. But I hope that all makes sense.
Yeah, it's OCD is one of those things that there's so many layers that I mean, we could go into a total geek conversation here if we wanted.
Oh yeah.
we'd lose the person who's new to this, who's watching us. But you're so right. I mean, there's so many of these intricacies, and that's why, going back to your point earlier, that's why it's so important to see someone as a therapist who's specifically trained to treat OCD, because there are so many special little areas that they got to understand how to work through and wade through. And if you don't have that, you're spending your money, and typically you're not getting any success because the person's not trained. And again, not their fault. It's just they just didn't have the training yet.
Yeah.
So that raised another question that I didn't think to ask before, which is, so we're talking about treating people with OCD and all of the work that your therapists do and the training they have and all. What happens? Do you ever get people who are like the spouse of or the loved one of someone with OCD?
Absolutely. We actually do family sessions because we know how much OCD can impact people's lives, but also their loved ones' lives. And most clinicians will probably ask for some collateral in session if they are treating someone. We also do separate ones, say an individual is not ready to get treatment, but their family members want education. We also offer those types of sessions. But yeah, I think accommodation from family members and loved ones is a huge thing with OCD, right? Because OCD thrives off reassurance, and everyday humans reassure each other all the time, right? I'm sure it's fine, you'll be okay, everything's all right, which is fine and dandy until you realize that that kind of stuff actually increases symptoms for someone with OCD. So family members, if you are experiencing loved ones with OCD, definitely call us to get an appointment to get educated on it, or see if you can join your loved one's session, because it's definitely a big part of treatment.
Yeah, that's something that that I come across a lot as well. Actually, I have, some of my clients are the spouse of someone with OCD, parent of, something like that, because they themselves are struggling with, how do I handle this when they're asking me to accommodate, and am I doing the right thing? Or I feel bad that I'm not accommodating because I feel that I'm making them more anxious. So it is truly a very interesting area. So as we wind down here, is there anything in particular that we haven't talked about that you think would be important for someone to know, or any questions or anything that you get that we haven't answered here that might be relevant for people to know?
Yeah, I think something that I'm very passionate about is this idea of choice. So something I like to teach all my members once I have some pretty good rapport with them is that compulsions are a choice. And I say that with the most compassion I possibly can, because I understand it's a hard choice, but someone with OCD will never get out of their compulsions if they don't truly believe there's a choice in them. And so I really say it with a stance of empowerment, because once people do realize their compulsions are a choice, it is quite empowering. And I think freeing is the number one word I hear individuals say. It feels freeing. It feels like a weight lifted off my shoulder, that I don't actually have to ruminate, and I don't actually have to go check the door again, and I don't actually have to wash my hands that fifth time. And so when you truly believe that you have a choice in your compulsions, I think your treatment becomes a little bit more clear. It's not any easier. So I think that's definitely something I want people to know. And then the other thing I'm very passionate about is that a lot of people don't know this, so I try to inform whenever I can. The place in the brain where OCD lives cannot understand language. And so when you try to talk yourself out of being scared of something, it just doesn't work. And that's why talk therapy is really ineffective for OCD, because your therapist is going to try to talk you out of being scared. They're going to try to rationalize. You yourself have probably tried to rationalize why your obsession is so radical and silly and doesn't make any sense, and it hasn't worked. And that's because OCD is in la la land when you are talking. So if you want to treat your OCD, you have to behave yourself out of it. You have to do the thing that you're scared of. You have to act in accordance with your logic. And know that you can't control your thoughts and your feelings. And I think that's another disservice we do as therapists, is because I think this applies more than to just OCD. You can't control the way you think and you feel. Every human on this earth has experienced a feeling that they really wish they didn't experience. And if we could control that, none of us would have experienced sadness or grief or loss, right? You can't control either of those things. You can only learn to respond and choose to respond differently. And so I want people to know that it's your behavior you have control over. Feeling comes after behavior. And I always compare it to the gym. You don't feel motivated before the gym. You might, I don't. It's always after, right? Because it's after the action of going.
Right.
You don't feel less scared after you've engaged in something scary. So yeah, I think those are definitely some key points I hope people can take away.
I love the way that you said that part of the brain with OCD doesn't understand language. That's so, it's such a clear, easy way to say it, and it's so meaningful. And I
Mhm.
appreciate you saying that. I've never heard that before, but I'm going to borrow that.
Take
Because-
it, steal it, run with it, teach it. Yeah, that's why I said it. So
Fantastic. Wow. Well, you've been a wealth of knowledge. So let me ask this: if somebody wants to get in contact with NOCD,
yeah,
they do.
visit treatmyocd.com, and you can sign up for a free 15-minute phone consult. They can run your insurance. They can, vet you with some questions to see if you're a good fit, set you up with an assessment. I also encourage you to watch we have live Q&As on YouTube. So we have webinars that clinicians themselves will answer. You can go and ask a question if you want. And then our app in the App Store is free as well. So you have access to a community bulletin of other people who have OCD, as well as, ability to create exposures. And that's actually the app you'll use in conjunction with a therapist here. You can text your therapist and everything through that app. So lots of different resources. So definitely use them. Even if you don't know if you have OCD, but you think you might, definitely reach out. The worst that happens is we, find something that's not OCD and help you link that way. But I mean, definitely get the help that you need.
Right. So the app in the App Store, would that also be Treat My OCD?
Yeah, it's NOCD and it's OCD Therapy and Tools.
Okay,
So,
and that's both iOS and Android?
yep.
Fantastic. Great. Okay. All right. Well, I really appreciate you taking the time. It's uncanny how you and I seem to have a very similar understanding to a lot of the things that we talked about, and it's nice to hear.
Yeah.
So to have a little bit of camaraderie out there in a very small field where a lot of people just don't understand. Why are you so interested in OCD? You must be weird.
No, it's so cool. And I appreciate you having me. I enjoyed talking with you.
Yes. So thank you so much. And I look forward to speaking with you again in the future.
Same.